Okay, let's get started. Good morning, everyone. Thank you for joining our webinar here. There'll be a few more people joining, I'm sure. Um, some of you may know me, some of you may not. My name is Dr. Jeff Shannon. I'm an audiologist and owner of Hudson Valley Audiology. We have two locations. We have one in Rockland County in Pomona, and we have a location in where I'm at today is in Goshen in Orange County. Um, so we're a private practice audiologist that sees patients for hearing, tinnitus, dizziness, primarily. Um, so the practice started in 1975. Obviously, I didn't start then. I joined the practice in 2010. And we have these monthly webinars that we give. And so today's webinar, I'm excited. Um, I formerly had a show on WRCR, which is a radio station in Rockland County. And I always heard these ads and people talking about Medicare Mark. Like, boy, this guy's interesting. Really like the content. Never got to meet Medicare Mark. And then a while back, I can't remember exactly when it was, Mark, but like we went to a business networking event and we met each other there. And I would say for the most part, we hit it off right away. We saw how we kind of, approached our patient care and our client care the same way. And so the idea was to have a webinar like this where we can share our databases and
Databases.
good education for patients. Sorry, I'm going to mute all again here. So this is where we're at. So some of you may know Mark Brownstein, but if you don't, he's going to be taking over the presentation here. Um, so he's the director of Medicare for Emerald Medicare. That's his business. I love the slogan there is taking the mystery out of Medicare, and I can't think that says it any better of what I think he's going to help us learn today. So he's a trusted advisor, and I think that's the most important thing that you'll learn today, that he's there for his clients. And without further ado, Mark, I'm going to let you take over.
Well, thank you, Jeff. And having been to your practice and worked with your incredibly kind staff, I feel like I've gotten an education just by going to your practice, getting my hearing tested, having a baseline, and understanding what the options are going forward. Since hearing, dental, and vision are topics that often come up beyond the normal decisions that people make. So, Jeff, kudos to you and your team. And then thank you for the invitation to educate people that I think know me and some people know you. And I think it's an important connection between the two of us to really help people understand an important area, which is hearing as one gets a little older.
Yeah.
So I'm going to go through this presentation. Some of you have heard me speak before, and I appreciate you continuing to listen to what I have to say about this Medicare industry that quite honestly is changing rapidly. This last open enrollment was the most intense open enrollment season I and anyone in the Medicare industry has ever been through. And part of that is because of the big, beautiful bill, which we're now calling OB3. But it was also because of the last administration, which was the Inflation Reduction Act. So there's been a lot of changes recently over the last 2 years that have completely changed the marketplace. And the changes that are coming are still to come. So in 2026, there's going to be more changes. So I'm going to go through this presentation. I wouldn't say I'm going to race through it, but I'm going to go through it as best I can. And then at the end, give Jeff a little bit of an opportunity to speak a little bit about the wonderful work that they do. But I always say people shout from their rooftops on questions around Medicare. We get very much similar questions every day, but for everyone, their situation, we really want to help people understand whether it's Part A or Part B, or whether it be the hearing or whether it be the dental. There's Medigap and there's penalties. So people really do want to understand this, and they have their own specific questions that they want answered. And that's what we're here for. We have a team of 7 people. We've got over 3,000 clients, and we work as hard as we can to support everyone, make sure we do what's in the best interest of every client we serve. So healthcare costs are really an important component of people's financial planning. Healthcare costs are very important, and the importance of it is really growing for people who are 65 and above. Um, you know, some people are on real. And so healthcare costs are a part of it. Dental concerns, drug costs are all a big concern. All of those things come up. They're expensive, and that includes hearing. So getting a good hearing aid is really important because there's a lot of off-the-shelf hearing aids that don't necessarily serve the purpose. Um, but the increases in Medicare have been about 5% over the last 3 years. The Social Security increases over the last 30 years have been only 2.3%. This year, from 25 to 26, Part B premiums went up 11%. So that's way above the average over the last 30 years. For those of you who are collecting Social Security, the Part B premium is automatically coming out. For those of you who are paying Part B out of your cash flow, you are seeing the impact even more dramatically. And then there's this income adjustment component, which for high income earners, there's a whole chart of 6 different levels of Part B premiums that get added to the cost for just the government piece. The average cost of healthcare in America is about $11,000 per year per person, per man, woman, and child. $4.5 trillion is spent on healthcare in the United States, eclipsing the gross domestic product of many third world countries. But what's interesting is that 50% of all medical costs in America are actually connected to pre-diabetic insulin care and medications. In addition, poverty accounts for about 60% of all healthcare costs in America. The majority of those folks who are in some kind of a low income status are in either what's called a dual plan, which is Medicare and Medicaid, which is under some scrutiny these days, and or Advantage plans. And so, it's really important for people who are on these plans to get the preventative exams so that they don't wind up in the hospital, which is the biggest cost. 63% of people really age 65 consider healthcare to be their number one concern. And most Medicare enrollees really worry that they'll get this important decision wrong. The anxiety that we hear, we feel, we address, not just during open enrollment, but all year long, is really significant. People get very emotional, very stressed about this particular area. But health insurance is different for everyone. Everyone on this call has different doctors, has a different budget, has different medications, has different travel needs. And so if some of you are actually on currently a group plan or on a retirement plan from the company in which you worked for, the question is how does that compare to Medicare? And so all the time, I am constantly looking at people's retirement group options or their current plan that they have with their company. Because sometimes people are paying a small amount of premium out of their paycheck, and sometimes it's a significant amount of money, or they have a high deductible where their deductible is $4,000, $8,000, and Medicare may in fact be the better option. So objectively, independently, I look at these what's called a benefit summary to really evaluate whether these group or retirement coverages are better than Medicare or not. I will always do what's in the best interest of the client. To look at the premium costs for the employee, for the spouse, and or any children that might be on the plan. Are there substantial savings or not? And that's the analysis that's really important to be done to make sure that going on to Medicare is the right decision at the right time. But people utilize their coverages differently. Some people barely use their coverage. Some people use it a lot. So when you look at the copays, deductibles, and the out-of-pocket maximums, these are the things that really are important to look at. Same thing with Medicare. Medicare, especially the Advantage plans, have copays, deductibles, and out-of-pocket maximums. So one needs to look at that. But in talking to a lot of people recently, some people have a new plan readjusting in the new year. So the plan will refresh the deductibles and the COPE and the out-of-pocket maximums will refresh January. Spoke to someone today, it refreshes May 1st. So that's when people are looking, when their plan refreshes, if they've met some of their out-of-pocket maximums, maybe that's the right time to consider Medicare if you've gotten to some of those high deductibles or out-of-pocket maximums. But this transition, the transition to retirement, that's really where the impact is felt. And people all of a sudden realize that this is the first time they've actually had to make this Medicare decision on their own. If they're working for a company, they are given a few options, maybe a high deductible plan, maybe an HMO, maybe a PPO, but they're not actually looking at the total range of options that are available in Medicare. So it's a little bit overwhelming. And that's where we take the time to explain to people what their options are based on doctors, medications, travel, and budget. But these coverages vary by state and even by county. The Advantage plans, the prescription drug plans vary by county. The Medigap plans are often called Med Supplement, vary by state. And so all of those things are a part of the discussion. But each year, during the open enrollment season, October 15th through December 7th, it's important to evaluate your coverage. You get things in the mail, you see things on TV. You really are people are overwhelmed, but it's important to know that you have an agency, a broker, a team behind you to really be able to answer your questions and not always call an 800 number. But is original Medicare automatic? The answer is both yes and no. If anyone is collecting Social Security before the age of 65, they will automatically be enrolled in Part A and Part B. Part A, which I'll speak of, hospitalization, is premium free. So that's no issue about getting Part A. Part B, on the other hand, has a premium based on your income from 2 years prior. So for people who are working for a company of larger than 20 employees, they don't need Part B. They might want it based on the cost of their premiums or their out-of-pocket maximums. But if they don't need Part B, they need to return that card, sign the back of that card, and return it to the Social Security office so that they wind up with just Part A at no cost. Many people wind up with Part B, didn't need Part B, and been paying that premium for a long time. So that's an important decision. One of the most important decisions is the timing of Part B. A lot of people, I would say 75% of the people are collecting, they have Part A at 65 because they're told they have to, or they'll get a penalty, which is not correct. There is no penalty for not getting Part A at 65. That's really important. So signing up for Part B is really based on the size of the company that you work for. If you are unemployed, self-employed, or working for a company of less than 20 employees, you must go on to Medicare. You can keep your group coverage if you want to, but Medicare needs to be primary. There have been many, many issues about people actually not getting Part B when they needed to, and they had to pay the 80% out of their own pocket that Medicare should have paid for. So again, an important part of the conversation about Part B, one of the biggest conversations we have every day. But you can defer Part B if you're working for a company of greater than 20 employees. Again, people just want to have peace of mind on this. Again, unemployed, self-employed, or working for a company of less than 20 employees, one must get Part B. So what is Original Medicare? Well, Original Medicare is 80% coverage, and it does not include prescription drugs. People like Original Medicare because they can go to any doctor they want anywhere in the country that takes Medicare. Part A is hospitalization, skilled nursing, hospice. It's generally free. For people who are coming from other countries or haven't worked or their spouse hasn't worked for 40 quarters or 10 years, you can buy into Part A. Part B, on the other hand, is all of the outpatient services, all of the preventative exams, all the diagnostic tests, the specialists, the doctors, the x-rays, durable medical equipment, all of that is Part B. But again, A and B alone is only 80%. So people need to actually supplement that in some way. But Original Medicare doesn't cover everything. I highlighted the three things that often people ask for: dental, eyeglass contacts, and hearing aids. It is in almost every conversation that I have, and I explain it to them. And these advantage plans cover a little bit of each of these, but certainly not to the level that people actually feel like they had expected it to be. But there are other things on this list: meal delivery, acupuncture, nursing home care. So there's things that original Medicare doesn't cover, which is why the Advantage plans have become so popular, because some of these things are partially covered, and they are certainly marketed very strongly. If someone has Medicare Part A and they are retiring, they need to get Part B. Very quickly, there are two forms. This enrollment in Part B, you sign it, you put a date. You want Part B for June 1st, 2026. You put the date on the bottom of this form. I want Part B 2020, June 2026. The other form is signed by your employer. Again, this is a company that you've worked for, and they're going to verify for you and or your spouse that you had credible coverage so that there is no penalty. This is the form. These two forms we fax to the Social Security office, your local one. We've been doing this since COVID, and it works well. Some people drop it off, some people upload it, but we will fax it as a courtesy. But these are the two forms that will get Part B. The income adjustment piece. People are surprised by this because if their income tax return from 2 years prior is above 109 as a single person, 218 as a couple, they have an adjustment. So under that, it's 202.90. Above that, you can see the brackets go up. And not only is there a income adjustment for Part B, but above that first bracket, there's an income adjustment for Part D as well. Again, a lot of the folks have worked and made good money, especially with two people working, but this is the chart that you need to understand. But there is good news. The good news is that there's what's called a life-changing event form. This form allows you to estimate, I repeat, estimate your 2026 income and get an adjustment based on the new bracket that you would fit into. So if you were working and you made good money in 2024, but in 2026 you're retiring and your income is going to drop, then you can fill out this form, and you can get it reduced. Again, there's other things like marriage, divorce, death of a spouse, and then obviously work stoppage and work reduction that allows you to file this form, and you can file it in consecutive years. These are the enrollment periods. The 7-month window that people talk about is 3 months before the month of your birthday, the month of your birthday, and 3 months after. This is really for people who are self-employed, unemployed, or working for a company of less than 20 employees. But people are very curious. They're getting mail in their mailbox. They're getting phone calls, and they just want to know what they're doing is right or wrong. So this is the time when all of a sudden things percolate. But annual enrollment is for those people who are actually on Medicare, who actually want to consider a change. With all the changes that are going on each year, as I said at the beginning, this is the time when it's absolutely overwhelming for every single agent and agency in this country. We must have handled near 1,000 people between October 15th and December 7th. Because some policies, plans were terminated around the country, they actually had an extension till the end of December for some people. And then there's still the next one, which is open enrollment. This is the period from January 1st to March 31st. This is for people who are on an Advantage plan and maybe want to switch to another Advantage plan because they went to their doctor and that doctor wasn't covered and they were sold a bill of goods by some 800 number, and they want to change to another Advantage plan. You can also change from an Advantage plan back to original Medicare from January 1st to March 31st. So we're still in that time frame. So we're still helping people who are still trying to make changes. The special enrollment period, this is really mostly for those folks who are losing their employer coverage. So if you're retiring the end of May, and June is when you want to go on to a Medicare Part B and a supplement, you have a special enrollment period that with those two forms that I showed you earlier, you simply transition from one to another very smoothly without an issue. But if you're moving out of your state or your county, there's also FEMA related. There's fires, there's hurricanes, there's all kinds of weather related activities, including the snow, that the insurance companies and CMS, the Center for Medicare and Medicaid Services, actually allow people to still make changes. So again, working with somebody who knows the ins and outs of this business is really important. You really have four choices when it comes to going on to Medicare. You can stay on your employer group plan, and again, review that benefit summary. See what you have, see what your options are, see what it's going to cost for you and your family. It may be the better plan, and it may not be. And it's really important to get that benefit summary from the employer or retirement package. If you leave that plan, it's very likely you may never get it back. So I'm always going to err on the side of really understanding that employer group plan. Original Medicare, as I said earlier, is an 80%. That's what's covered. You have a 20% exposure. It's risky, and it has no Part D prescription drug plan. But again, any doctor that takes Medicare, that's why people like Original Medicare. The Advantage plans, these are actually 60% of all Americans around the country, not necessarily in the Northeast, but around the country, have these Advantage plans. Yes, they include a drug plan at no additional charge, but there's copays for everything. There's networks, in and out of network. One of the biggest changes in this country that has gone on into 2026 is the PPO model is actually fading away. They want you to just stay within the network. And so HMOs are becoming the new options that all these insurance carriers are forcing people into. PPOs still exist in some carriers and some parts of the country, but they are not as available. These are the kinds of plans that offer a little bit of dental, a little bit of eyeglasses, a little bit of hearing based on the carrier and based on using their specific network of providers, specifically hearing, eye, and dental. The Medigap plan, the supplement plan, these are expensive, okay? But if you live in South Carolina, it's different than you live in Connecticut, New York, or New Jersey. But these plans are the best plans in America because you can go to any doctor you want anywhere in the country that takes Medicare. But you need to add a prescription drug plan. And so those premiums for those prescription drug plans, some places are as low as $10 a month. In some cases, it's up to $45 a month. So it really depends on where you live relative to the cost of prescription drugs. The single biggest changes in the last 2 years that have occurred in this industry has been prescription drugs. And I'll go over that a little bit more. But there's when you have a Medigap, you have to add a prescription drug plan. It is risky to not have a prescription drug plan. Because then you may be paying retail. But with the high cost of prescription drug premiums, people are actually using GoodRx. They're using other options. But these supplement plans are the best. They generally have a $283 deductible for the entire calendar year, and that's it. So again, based on the state you live. So as I said earlier, these HMOs and PPOs is a big change. HMOs are on the rise. They're expanding because they're efficient and they're profitable for the insurers. So there are many less options for PPOs. People like PPOs, but PPOs likely have higher premiums and less benefits. So everyone's consolidating under a provider network where the doctors and the hospitals and the specialists are all contracted under one roof. So the Advantage companies, most of these are familiar to you. United Healthcare has a huge market share. Humana, also a huge market share, less so in the Northeast than it is in the South, but it's still nationally huge market share. Aetna, like Aetna a lot, good company. Anthem is one of the other companies. Kaiser Permanente is certainly a company that's in other places in the country. So these are some of the leading Advantage companies. So when it comes to these Advantage, depending on where you all are, there's MVP, right? There's other carriers that are either local, regional, or national. And some of them had local networks, regional networks, and national networks. So you can't assume that even a PPO will give you access around the country. The supplemental carriers, you can see there's a lot of them. In the New York area, There's only really one leader right now, and that's United Healthcare. But in other parts of the country, certainly these other carriers work. The below the line carriers are carriers that are creating lower pricing, but they're not a name brand that everyone knows about. But people are wanting to save money because in some areas of the country, including the Northeast, the cost for these premiums for these Medigap plans could be near $400 per person. The prescription drug market is incredibly volatile. Um, they have actually, we do the work, we've been doing the work. We actually have worked tirelessly in this area. They have actually stopped paying commissions to all brokers around the country, but this is critical. We have to do this work because people have to understand what their costs for prescription drugs are, and this is their biggest area of stress. The annual deductible is $615 for 2026, but that's only for brand named medications. The generics don't fit under the deductibles. The donut hole has gone away, right? In 2024, the maximum out of pocket was $8,000. It was lowered to $2,100 in 2026. It was $2,000 in 2025. For many people that we speak to, this is a game changer. So the maximum, not the premium, but the maximum out of pocket for all Medicare approved drugs is $2,100 in 2026. But these prices change yearly. There are preferred and there are mail order pharmacies. So, one has to really look at where can you get the best pricing? Is it GoodRx? But not having prescription drug plan is dangerous. But these are some of the options. GoodRx. The Canadian store is actually a Florida-based company, which I like. Trump RX came out with a whole new model, as many of you know, connected to Mark Cuban. All of these options are available. It's the brand name medications where international pharmacies are still the best option that's out there. So for 2026, these are, at least at this point, these are the reductions that are being seen on some of these medications. And this is really an important set of changes. There could be a lot more, but these are fairly popular medications that people are beginning to see some price reductions. Hopefully there'll be more. 10 is a small number compared to the number of medications that are actually out there. But people who are spending a lot of money on medications at least now have a $2,100 limit to that. The dental benefits. No one's ever satisfied with their dental benefits, even when they have a dental plan. But I can tell you that dental benefits are, in fact, helpful. And as you get older, you actually need what's on the right-hand side of the screen, not what's on the left side of the screen. On the right side of the screen is really the comprehensive work. In almost every plan I've ever worked with, it's covered at 50% only. So if you have a $1,000 root canal, you're paying 500, the insurance company is paying 500. And even though people expected to pay more, that's really the model that's out there. Some of these standalone dental plans, you can get $1,000 worth of coverage. You can get $5,000 worth of coverage, but you have to understand that you will pay probably 50% of the major work that needs to be done. Some of them cover implants, some of them don't. Some of them have a waiting period. I often say to people, if you're going to look at dental coverage, when you leave your company, see if you can keep the company's coverage that you've had. You'll probably eliminate the waiting period. You're comfortable with the plan, and maybe your dentist already takes it. The dentist will probably offer you some kind of a plan internally that covers routine exams and cleanings, but not really the restorative, the comprehensive. They'll give you a discount, but it's better to have a dental plan. But those plans cost between $35 and $90 a month per person. So this big, beautiful bill, many people are calling it OB3, is really a major healthcare reform bill with really long-term impacts. It's really a 10-year plan. It's changes to drug pricing, insurance policy, AI, and tech. But the impact on the consumers, on all of you, is you're going to see incremental but steady increases in all areas. So it could be as simple as you're used to paying a copay. That copay can revert to a co-insurance. If you have a copay of $100, but you have a co-insurance of 10%, that 10% is almost in all cases going to be higher than your $100. Those are the changes that people will not recognize and notice, but those are incremental, steady increases because the insurance companies, even though people don't believe this, they are truly in self-preservation mode. They are making changes right now, and they have through the last 6 months as this big bill has been implemented. They have had to make changes now for staffing and for the future. They're 30% of all rural hospitals are closing because they are no longer going to get the Medicaid dollars. So these dynamics are influencing the policy changes on Medicare Advantage, Medicare, Medigap, group plans as for companies as well as Medicaid. So every part of the insurance industry is being influenced by this bill because people are nervous and they don't know how it's going to impact. They don't know whether they're going to survive, and they have to make adjustments, and they'll take it out on the consumer before they actually lose money and impact their investors. So it's going to be a trickle down. And different regions of the country are going to be impacted differently. Some are going to have flat cost increases and some are going to be larger. On these Medigap plans that some of you may have, the price increases on the average was 4 to 6% a year. The increases now are between 10 and 20% a year. That's huge. So the impact on the hospitals, staffing shortages, reduced services, rural areas are certainly going to be hit harder, but there are places in New Jersey and upstate New York that are already closing. I think one actually in Westchester. So it's really happening, but also clinical trials. There's difficulty in recruiting participants due to the immigration and visa hurdles impacting medical research. So the economic ripple effect will have long wait lines, local job losses. So there's a lot going on. None of this is being talked about on the news at all, but I do because I want people to understand what's going on. So I'm going to just do a slide or two on hearing, and then I'm going to ask Jeff to speak a little bit about it. But hearing loss is serious, and it's lonely. It creates loneliness and isolation and depression, and increases falls by 50%. And so there's a lot of people who have measurable hearing loss, and a lot of them are not taking care of it. But there's also a bias around hearing aids, is that you look at that 63% of millennials and 47% of Gen X and boomers, there's a bias around some kind of weakness around having a hearing aid. But people wear glasses. People, there needs to be, there's nothing shameful about it. So I want Jeff to just speak a few words about some of the hearing work that you folks do as an add-on to what I'm speaking about as well, please.
Yeah, thanks, Mark. First of all, I see that people have put, can you hear me okay, Mark?
Yes, I can.
Okay, just want to make sure. I see if you have questions, please put them in the chat bar. You can see that at the bottom of your window for Zoom, and there are some questions there that we'll get to. But yeah, I do want to talk about hearing and audiology a little bit. So these statistics are there. We know that. On average, it takes someone 7 to 10 years from the moment they have a hearing problem until they actually take action. Now that window is starting to shrink. So people are taking action earlier. There's more awareness. There's more options, and there's this medical side of things as well. And I was talking to Mark earlier about audition and cognition, and about hearing in the brain. And there's much research going on about how the risk of dementia and Alzheimer's is related to hearing loss, in that someone with mild hearing loss is twice as likely to have dementia later in life. Someone with moderate hearing loss is 3 times as likely, and someone with a severe hearing loss is 5 times as likely. So there's a medical reason to this as well in regards to hearing. We also see patients for dizziness, whether it's vertigo or feeling off balance, and tinnitus, which is one of my specialties. And so, again, now than ever before, we have new treatments available. So it's a really exciting time in the world of audiology, and how we can treat and test our patients. Specific to insurance, I can't speak for all practices. Our practice, we participate. We're in network with Medicare and just about all major medical insurances. But we see patients that have Medicare, and we have patients that have Medicare Advantage or one of those types of insurances as well. Um, as it relates to treatment, if we see a test a patient and they're found that they are a good candidate to do a trial fitting with hearing aids, cochlear implants is a different story, but specifically with hearing aids, Medicare does not currently cover treatment. It does not cover hearing aids. There was a bill several years ago that was going to have a small benefit that did not get passed, but that's something worth knowing. Sometimes the secondary has a benefit. This is my staff is tasked with making sure to testing and determining if there is a benefit for the patient. And Medicare Advantage plans sometimes have a benefit, and sometimes they have something. We kind of got into this a little bit of having what's called a third party option, where you have this ability to get a hearing aid through a company that provides sort of a basic service there. Um, that is not, we don't participate with those. And the reason for that is because it doesn't, I was telling Mark, doesn't follow best practice. It doesn't have the best interest of the patient. It saves the insurance some money, but it's not what's best for the patient. And I can get into more of that, but as those reasons why. But from the standpoint of your insurance and how it helps with in the field of audiology, knowing that many people are surprised that they can come in, they have Medicare outside of their annual deductible at the beginning of the year. It's Medicare covers 80% of that, and then the secondary covers the other 20%. So they're sometimes surprised that that is covered by their insurance. And so we always encourage patients, just like Mark has, to come in and get at least a baseline test just to see where things are for the standpoint of your communication and where you're at with all of that, but also from the medical side of things too, and all the comorbidities that we know of as that are related to hearing.
But I just want to have one more slide here,
Sure.
and that I just want to make sure that people understand a few things. One is the changes that occurred within 2026. Part B, premium 202.90 at the baseline. Part D deductible for the prescription drugs up to 615. The Part B deductible for those on Medigap is now 283. The maximum out of pocket, believe it or not, on the Advantage plans are 9,250. I've had two people in my entire career who ever gotten there. New York is one of the few states. New York, Connecticut, Massachusetts, and Maine is one of the few states in the country where you can switch from an Advantage plan to a Medigap plan without any health questions. But it's important to recognize the importance of knowing your plan, the potential costs, the importance and the integration of healthcare and financial planning. And I always encourage people to advocate and appeal. When you get a bill that doesn't make sense, right, make sure that you appeal it. 1% of the people out there appeal. Of the people that appeal, 50% win. So it's really worth appealing. It's time consuming, and not everyone has the energy and knowledge to do that. But seek objective information. Find a trusted Medicare resource. During that open enrollment period, October 15th through December 7th, keep your eyes open for changes. Reach out. The decisions at age 65 and retirement is really when all of this begins to happen. Don't wait too long. There are people who certainly I talk to that have waited and have no coverage or just A and B, and they're at risk for 20%. Review your doctors and meds, understand Advantage and Medigap. And this is our team. So I thank everyone for being a part of this. Thank you, Jeff, for the opportunity. Again, our contact information is in there. I will work with my team to sort of cover, send out the recording as well as my PowerPoint that went out in a PDF. I think we're good.
Yeah, yeah. Thank you so much. It was really great, Mark.